Now let's go over Obamacare, or officially the Affordable Care Act of 2010. What did that do? What was it trying to fix? And how successful was it? And what has it done since then? So, the Affordable Care Act. Some background. So, in 2010, 50 million Americans lacked health insurance. Right? That's a lot of Americans, and that's a lot more than today. Right? If you remember today, only 8% of Americans lack health insurance. 50 million Americans is more than 8% of Americans. That's a lot of Americans. I don't know exactly how many Americans that was in 2010, but it was a lot. Some of those were robust people who, didn't want insurance because they knew they were healthy and were unlikely to get sick. Some just didn't get their insurance through their employer, right? And so they just didn't have insurance because they couldn't get it through their employer. Some were low-income people who were frail, right? So these are people with pre-existing conditions. This is a big talking point was a big talking point to sell Obamacare. It remains a big talking point today, where people with pre-existing conditions often paid prohibitive premiums, and many of them could not afford insurance. Now, side note, on sort of sidebar on pre-existing conditions. I've mentioned this before, but before Obamacare, health insurance was insurance in that, you were insured against bad outcomes. Post-Obamacare, once you require people to cover pre-existing conditions, right, where the insurance company is required to pay for my Qulipta, and they can't charge me more, even though they know I'm going to need Qulipta because of how bad my migraines are, right? They have my medical history, they know that, but they're no longer allowed to, charge me a higher price for that. At that point, you go from insurance to a combination of insurance and redistribution. So, right, one of the things that you may remember from the Bismarck system, where I said the rich pay for the rich and healthy pay for the health care of the sick and unhealthy, and it's not just insurance; it's also redistributive, right? Where it's not just that they're paying for risk; it's that it's not a risk. Like the insurance company isn't. There's not a risk that I'm gonna pay $1,400 for Qulipta every month. I am going to pay $1,400 for Qulipta anymore every month. That is not actually a matter of insurance. When my quote unquote insurance pays for my Qulipta, that's not insurance, that's a handout, right? And so the Obamacare really transferred insurance companies to selling insurance to also being a tool of redistribution. And in some ways that's very sympathetic, right? Like somebody who has terrible migraines, right? Yeah, maybe we want to pay for their treatment. Maybe we actually do want to redistribute some money to people who have terrible medical expenses so that their lives aren't horribly impacted by those medical conditions, right? Like maybe that's something maybe that's something we want to do. But once you start relying on insurance to do that, you're kind of turning insurance into something more than insurance, right? It's no longer just, right, if you go back to the halcyon days of the Rothschild-Stiglitz model, right? The only difference between the frail and the robust people was the odds they were going to get sick. Once we guarantee that frail people, have to buy Qulipta every month, there's not risk anymore, right? There's not a risk I buy Qulipta. I buy Qulipta, right? That's not a risky thing. That's just something I do. And so once you require health insurance companies to cover pre-existing conditions and not charge people who have pre-existing conditions more, you've gone from insurance in some ways to redistribution, right? Where you're redistributing money from the healthy and wealthy towards the poor and the sick. And maybe that's good, but you should recognize that that's not the same as insuring people. And now, and sort of after Obamacare, you move from a model where health insurance is insurance to a model where health insurance is both insurance and a tool of redistribution. We'll come back to that a little bit later. The Affordable Care Act moved the U.S. towards a more Bismarckian system. We've been moving in some ways, and we've sort of, in some ways we've become more Bismarckian since 2010, and in other ways we've become less Bismarckian. I'll cover some of both of those. Parts of the Affordable Care Act have been overturned, either by the courts or by later legislation. Parts of it are still in force today. So what were the goals of the Affordable Care Act? There were three main goals. The first is to expand coverage and reduce the number of uninsured. The second is to reduce healthcare costs. And the third is to improve the healthcare delivery system. So let's back up a bit. Why do we care about people not having insurance? Like, if you don't want to buy insurance, why do I care you don't have insurance? And there's a few reasons for that. One is paternalism, right? Where I think I know better than you. Where you don't buy insurance, and I think you're an idiot for not buying insurance, so I'm going to make you buy insurance. Right? That's one reason. Another reason is equity. Right? So equity is, right, so if the rich can afford insurance but the poor can't, on equitable grounds, you might say, that's not fair. Let's make sure everybody has access to a baseline level of health coverage, right? So that's one reason you might care about people not having insurance, is if it's low-income people not getting insurance. That's a sign of an unfair society, and we may want society to be fairer than that, right? And then the last reason we might care about people not having insurance is externalities. So communicable diseases, right? Next week we're going to cover sort of externalities in healthcare. There are a lot of them, right? But if you get sick, you run the risk of getting me sick. So I have an interest in trying to keep you healthy, because if you're healthy, there's less chance I get sick from you. And then there's also financial externalities, where uncompensated care and implicit insurance cost about $41.6 billion in 2019. These costs are borne by hospitals and insured patients and insurance companies. And then there's also, right, if people don't have insurance, they tend to use less efficient means of getting care. So, for instance, it's well documented that low-income people will use the ER for routine care. Because, they don't have insurance, or they don't know where to access routine care. And so I'll note just an anecdote on this. I mean, you've heard me complain about how crowded the UChicago ER was and how long the waiting times were. The only exception to that was at the start of COVID, when the UChicago ER was empty. And that's because, in part, a lot of people in the UChicago ER were going there basically for a general checkup, or for something you would normally see a regular doctor for. They went to the ER for, right? And so a lot of those cases weren't real emergencies, which is why they stopped showing up in the ER during COVID. Now, some people may have stayed home even during a genuine emergency because they were terrified of COVID. But at the start of COVID, all the people who were using the ER for routine care stopped showing up, and all of a sudden, UChicago, which UChicago's hospital serves a low-income population, a lot of them who were using UChicago's hospital for routine care stopped showing up. And this is inefficient, right? ER practices, ER rooms are not designed they're designed for emergencies. They're not designed for routine care, right? We want people who need routine care going to places that specialize in routine care. That's more efficient, right? And if you're not insured, but you're implicitly insured, you go to the ER for your routine care, and that's inefficient for everyone, right? So we can improve efficiency if we give people health insurance by ensuring they see a general practitioner for routine care rather than going to the ER. U.S. healthcare costs. Why do we care about healthcare costs? Well, I've mentioned a few times through this course that the U.S. has insanely high healthcare costs. It's nearly 18% of GDP, and it was around that high when Obamacare was passed. It was only 5% in 1950. It's the highest of all OECD or developed countries, right? Both by absolute magnitude and by proportion of GDP. Nearly half of this spending is via the government. It's nearly a quarter of the federal budgets. It's nearly a fifth of state and local budgets. And Americans, despite spending all this money, we are less healthy than many countries that spend much less money on healthcare than we do. And healthcare costs are projected to continue to rise, right? U.S. healthcare costs are projected to only get larger unless something is done and people are doing things. And we'll talk about some of those. And in case you're curious what the distribution of healthcare expenditures looks like in 2015, 38% of healthcare expenditures were from hospital, 23% were at doctors and clinics, 12% were for prescription drugs, and 27% were for everything else. So what was sort of the core of the ACA? There were three legs of the ACA that sort of the ACA was meant to stand on to reform the U.S. healthcare system. The first is that it regulated insurance markets for individuals. It banned charging sickly people or people with pre-existing conditions extra for their coverage, and it prohibited denying them coverage, right? So on the one hand, making sure that saying that you can't deny someone for a pre-existing condition, that's a really popular position, right? I think on sort of fairness grounds and humanitarian grounds, people are like, yeah, insurance companies shouldn't be able to deny people coverage for pre-existing conditions. The problem with that is it's going to exacerbate adverse selection. It's also going to set a minimal standard of care that insurance plan had to cover, which it side note is going to reduce adverse selection because the robust cannot get below a certain quality contract, right? There's a limit to how much they can try to get out of paying for insurance. It instituted an individual mandate, so individuals had to buy health insurance, right? That's going to reduce adverse selection. And then lastly, it expanded Medicaid. So let's do a deep dive into the changes in regulations to the individual market. So one of the most consequential changes was that insurers could no longer discriminate based on pre-existing conditions. So this is great for me. This is fantastic for people who have migraines, right? Before this, a physician would examine you if you wanted to buy private insurance, right? They would see your heart rate, how healthy you were, how much you weighed, and then they would tell the insurance this person's high risk, low risk, medium risk, and the insurance would price you accordingly. This process of setting the price was called underwriting. It was very opaque. It was not clear, how it was done. It made it so it was, even though insurance companies did offer different prices, it was difficult to tell which insurance companies were offering different prices, and so it became very hard to compete on price in the insurance market. And it's worth noting that requiring covering frail people is called a guaranteed issue rule. So if you hear a guaranteed issue rule, that means you have to provide insurance to anyone who asks, right? You can't deny them based on their pre-existing conditions. Now, if they're not willing to pay your prices, you can say, no, you're not paying our prices. But if they're willing to pay your prices, you have to accept them. Premiums can now only be based on location, age, and tobacco use. So no other risk factors are allowed to be considered. Obesity, heart disease, family history, etc., all off the table. And this also instituted community rating for individual plans, where individual plans, right, that before Obamacare, you would be priced according to your personal risk. Now the premium you pay is based on the overall risk of everybody in your insurance plan together, right? So this is for more on community rating. See the lecture on Bismarck systems. So before the the Affordable Care Act, as I mentioned, customers would see personalized options for health insurance. Now that's not necessarily a good thing, right? If you're healthy, that's great, but if you're sick or have pre-existing conditions, your personalized options are pretty terrible. Because the insurance company knows you're going to cost them a lot of money, so they're going to offer you a pretty lousy deal. After the Affordable Care Act, all customers in the same area with the same age and tobacco use saw the same plan. So I don't smoke. Let's say you're also 27. You also don't smoke, and we both live in Prince George's County in College Park. We are going to be charged the same amount, even if I have migraines and I'm going to cost everyone in the pool a lot because they're going to need to pay for my Qulipta, right? This is good for frail patients with pre-existing conditions, but it's bad for robust, healthy patients. Each state was required to set up marketplaces where people could buy insurance, and people received subsidies based on their income. And they also implemented risk adjustment, where if Puckney's, this is covered in the Bismarck lecture, but if Puckney's insurance company enrolls a bunch of really healthy people, and Sterling Insurance Company enrolls a bunch of unhealthy people, Puckney's insurance company is going to need to compensate Sterling Insurance Company because Sterling Insurance Company, they have a much less healthy group. And this is going to sort of force people to pool even across plans effectively. Plans must cover essential health benefits. We'll get into that next, next slide. And plans have 4 metal levels with different co-insurance rates. So plans became standardized. There are now 4 levels of co-insurance rates. There's a 5th, which is a complicated version of silver, but I'm not going to cover that here. Bronze is the worst. That covers 60% of your expenses. Silver covers 70% of your expenses. Gold covers 80% of your expenses. And platinum covers 90% of your expenses. It also banned lifetime spending limits, where certain insurance companies would say, look, if you end up with MS, right, and your costs go through the roof, we're going to pay for a maximum of $1 million of care over the course of your lifetime, and if you exceed that, you can no longer get more care from us, but you might still need to pay your premium or something. That practice was banned by the Affordable Care Act. Now if I'm insured and I get MS or some other terrible disease, the insurance company needs to continue to pay for my treatment. And again, just to emphasize this again, because this was such a big deal, it mandated that pre-existing conditions had to be covered. So in preparation for this class, I went onto the Maryland Health Insurance Exchange and I looked up, I entered my details and saw what plans I was eligible for. This is the first one that came up, right? This is from United Healthcare. I'm pretty sure that's the company where their CEO was recently assassinated by the murderous Luigi Mangione. You can see it's a gold plan, right? So it's going to cover 80% of my expenses, my health expenses, right? Now, I only would pay $1.46 a month after tax credits. That's insane. That's super cheap. However, has a reasonable annual deductible, right? So $1,000 would be my deductible. Annual out-of-pocket maximum, right? So that's the if I go beyond that limit, the insurance company pays for everything else. So if I end up with more, if my medical expenses would be more than $7,000, the insurance company will take care of the rest. I have a $10 copayment for primary care, so every time I show up to the doctor, I have to pay $10 for the copay. Every time I show to the ER, I have to pay $40. For urgent care, sorry, that's not ER services. ER services are $350 for a copay, right? They really don't want me using the ER. And I have a $10 copay for generic drugs, which is pretty cheap. This is estimated to cost me about $1,400 a month in total, right? My guess is that's total healthcare spending. Right, you can see there's more information about telehealth down here. And then once I see this on the market, right, once this shows up on the Maryland market, which I think is run by the Maryland state government, then I can apply to the plan, right, where I say, cool, I want this one, I hit the apply, and then I apply to United Healthcare. So that's sort of how the health insurance markets work. You can look up the one in Maryland, so you see what insurance policies you'd be eligible for and what your estimated premium would be after services, right? So again, these are the metal categories. So bronze, your co-insurance is 40%. Silver, your co-insurance is 30%. Silver with extra savings, co-insurance somewhere between 6 and 27%, depending on what savings you qualify for. Gold, 20%, and platinum, 10%, right? So platinum is the best, bronze is the worst. Now, what do plans have to cover now? They have to cover outpatient care, emergency care, inpatient care, maternity care, newborn care, mental health, substance abuse disorder care, prescription drugs, rehab, testing for various screenings, things like that, preventative services, chronic disease management. The dreaded pre-existing conditions come up, right? And again, chronic disease management is often not risky, right? It's often just something you pay for regularly. And pediatric services, right? So services for kids. In addition to regulating the individual marketplace, and instituting an individual mandate, which we'll get to soon, the Affordable Care Act also instituted an employer mandate. So what was this? It basically required that firms with more than 50 employees had to offer health insurance to employees, right? And this was in part to keep people off of the individual market, and so that they weren't getting subsidies, things like that. But if a firm who has more than 50 employees does not offer their employees insurance, they pay a $2,000 penalty per full-time employee, right? So that, basically, firms that have more than 50 employees now need to offer health insurance. It also, for small businesses, right, with if you had less than 24 full-time employees, you were eligible for a small business tax credit, which would, help you pay for healthcare for your employees. And the employer mandate is still in effect. The individual mandate was saying, as an individual, like you, Liam, need to have health insurance. And if you don't have health insurance, we're going to fine you. And what was that fine? It was the greater of 2.5% of annual income or $695, whichever one was higher. And so it's worth noting, this is much lower than the average price of health insurance at the time. So if I really don't want health insurance, a lot of people actually decided to just, pay the penalty and move on and not get health insurance because it wasn't quite high enough. This is designed to combat adverse selection, right? So if they're robust, leave the insurance pool, you charge them more money. This survived a legal challenge at the Supreme Court, only to be overturned in the 2017 Trump tax cuts, right? So part of the 2017 Trump tax cuts is they removed this penalty. So in effect, there's no longer an individual mandate because there's no penalty for not having insurance. Another thing the Affordable Care Act tried to do is tried to make health insurance more affordable. So in 2016, the average silver plan premium was $4,583. The federal poverty line was only $11,770, which meant that the silver plan was still prohibitively expensive for many Americans, right? How did they solve this? They used subsidies and Medicaid expansion. So let's start with the subsidies. So they basically capped the maximum out-of-pocket premium cost you could pay as a percent of your income, right? So if you were 100 to 133% of the federal poverty line, your maximum out-of-pocket premium expenses were 2. You could only pay 2% of your income on your premium. Meanwhile, if you're 300 to 400% of the federal poverty line, you could pay a maximum of 10% of your income on the premium, right? So and if you paid more than that, they would subsidize you, right? So this effectively increased the co-insurance, or I guess it decreased co-insurance, but it increased the percent of health expenditures that plans would actually cover beyond what their metal rating would suggest. So for a silver plan, which again, in theory, only covers 70% of your healthcare expenses, we can see that if you were earning between 100 and 150% of the federal poverty line, you actually were covered for 94% of your expenses, not 70%, much higher. For 150 to 200% of the federal poverty line, you were actually covered for 87% of your expenses, not 70, right? And then past 200, you get a lot closer to 70%. So these plans, buying these plans was highly subsidized for a lot of these people, especially low income. Now, how was this paid for? So the American, the ACA's coverage provisions, the Affordable Care Act coverage provisions cost $110 billion in 2016 alone, right? According to the CBO. That's a lot of money. How did they pay for this? Well, they increased taxes on high earners, both income tax and on unearned income. They instituted new taxes on medical devices and tanning salons. And they also cut Medicare. And the way they cut Medicare is by reducing the amount of payments they gave to providers, right? And then they also reformed Medicare Advantage, which had been costing the U.S. money. And unfortunately, Medicare Advantage post-reforms still cost the U.S. more money. So, right, Medicare Advantage is still a bad deal for the U.S. even today. It costs more than just it would if the people just stuck with Medicare Part A or Part B. So now let's talk about the Medicaid expansion. And this is well studied and it's a big deal, right? So this expanded Medicaid to all adults with or without kids below 133% of the federal poverty line, right? Which again, as a reminder, was $15,650 in income per year for a single adult in 2025. At first, all states were required to take the money, right? You couldn't refuse this. You had to take it. However, the Supreme Court ruled that states could refuse it, and some states did. This created, if you remember back to the earlier lectures, this created a natural experiment where some states received Medicaid expansions and some states did not. Now, today, what does Medicaid expansion look like? Well, the dark blue states all adopted Medicaid, and the light blue, the sort of teal states have not, or the green states have not, right? So who are the states that haven't adopted Medicaid? It's overwhelmingly the lower South. Though it's worth noting that Arkansas and Louisiana both adopted Medicaid, as well as Kansas, Wyoming, and Wisconsin. But 41 states at this point have adopted Medicaid. There are only 9 holdouts. But we can look at the effects of expanding Medicaid by comparing how outcomes differed in places that adopted that accepted the money to expand Medicaid compared to those who did not accept the money to expand Medicaid. So how did this Medicaid expansion and healthcare expansion work generally? It worked really well. So you'll notice across every racial group in the U.S., the uninsured rates dropped. And they dropped by a lot, right? So Hispanic and Latino were previously 30% uninsured. By 2019, it was less than 20% were uninsured, right? American Indians went from 30% to under 30%, to under 20% uninsured. The percentage of Native Hawaiian people who were uninsured fell. The percentage of Black people who were uninsured fell. All across all racial groups, we saw big gaps, big drops in, who was uninsured. Right, you can see the effect of getting rid of the mandate here, by the way, where from 2018 to 2019, after the mandate's repealed, we see Hispanic and Latino uninsured rate goes up, as does the Native Hawaiian uninsured rate. Other impacts of the Affordable Care Act, it does not, despite I mentioned that Medicaid expansion in theory would reduce employment, the Affordable Care Act seems to have had no overall impact on employment. So Lung and Moss in 2016, they compare states that have expanded Medicaid to those who did not. They find that Medicaid expansion increases coverage by 3 percentage points among childless adults, without any employment effects. So more people get insurance and fewer, and there's no employment effects. Duggan, Goda, and Jackson in 2017 also find a zero employment effect on average, but they find a more subtle effect where they say even though on average there's no effect on employment from the ACA, what actually happened is that middle income people worked less because the subsidies are based on income. So if they worked less, they got more subsidies, and that discouraged work, while lower income people worked more to try to qualify for private insurance, and sort of be able to qualify for the market, right? And so they find the ACA lowered employment for middle income people, but raised employment for low income people. It doesn't seem, the ACA doesn't seem to have any overall effects on health outcomes. There's some evidence of improved health among the older working-aged population, which was already like sort of the most vulnerable uncovered population in the U.S., right? They also find no evidence of increase in risky behavior, smoking, drinking, eating too much, etc. Total medical spending fell around $811 per person for people who got subsidized insurance, right? Total medical spending is premium plus out-of-pocket spending, so it does seem to have reduced direct spending by American consumers who got the premiums, right? That money has to come from somewhere. The study does not say, to my knowledge, where that study comes from or where that money comes from. It just says the people who received the subsidized plans tended to do better. And it reduced unpaid medical bills and debt by about $600 to $1,000 a person, according to WHO et al. 2016. So, what can we say about the U.S. healthcare U.S. healthcare? I mean, a lot of this course is kind of focused on U.S. healthcare. This lecture really did a deep dive into the U.S. healthcare and health insurance systems. It is a basket case, right? There are multiple insurance systems, right? So most people have employer-sponsored insurance. Medicare covers old people. Medicaid covers low-income people. State-run exchanges sell private plans to individuals that don't get employment, that don't get insurance through their employer. And for the people who don't have official insurance, we have implicit insurance. U.S. health spending is the highest of any country, both in absolute terms, right, in terms of raw dollar amount, and relative as a percentage of our GDP. Despite that, we have relatively poor health outcomes compared to similarly rich countries. The Affordable Care Act made the U.S. more Bismarckian. However, the individual mandate is no longer in effect. And the U.S. has begun to experiment with health technology assessment and price controls under both the Trump and Biden administration. All right, that was a long lecture. I will be covering. I will also be assigning an interview with Amy Finkelstein, given by Professor Sebastian Galiani, where she discusses four reforms she would make to the U.S. healthcare system, just to make it a little less chaotic and a little less nonsensical. Right? That implicit insurance thing. There's no way that's efficient, and it's just if you're going to implicitly insure people, you might as well give them official insurance and make it standardized and controllable. And that's what Professors Finkelstein and Galiani are going to discuss in the video you should watch after this. All right. I hope that this was enlightening and that you learned a lot. And I hope that this helped make sense of the very confusing U.S. healthcare sector. All right. I will see you all next week.